two of you have joined for today's very important masterclass for all of us, which is on interpersonal communication skills, or what you call is a non-technical skills for doctors. As you know, at SRCC Children's Hospital, which is managed by Narayana Health, it is all kind of management or treatment is available, which includes cardiac surgery, neurosurgery, solid organ transplant, bone marrow transplant, advanced laparoscopy, pediatric surgery, pediatric urology, and everything we can do under one roof. We have been doing regular deliveries of normal as well as high risk fetuses for quite some time. So I think all of you know about that. So today's masterclass is, as I told you, non-technical skills, and we have galaxy of speakers, starting from Dr. Bela Doctor. She will be speaking on doctor-patient communication as well as how to take care of psychological aspect once the patient is admitted. She is a very senior pediatrician, and she has been trained in UK, and she is with SRCC since the inception of the hospital. She runs quite a few programs, including Family First, and she will be telling us about doctor-patient communication. After that, we have Dr. Zubin Pereira, Dr. Suganti Iyer, and Mr. Gautam Tiwari as a speaker. So with this, I invite Dr. Bela Doctor for taking over and continuing with this particular masterclass. Bela Doctor, please come over. So she will be coming here. Yeah.
Thank you, Dr. Rasik, for that very glowing introduction. I don't know if I deserve all of it, but thank you again. So today we'll be talking on a very important topic, something that I wish they would teach us when we are in our MBBS days. Because I think patient and doctor communication, it is one of the most important things in our practice. They say that medicine is an art whose magic and creative ability have long been recognized as residing in the interpersonal aspects of the patient-physician relationship. We all keep talking about how our bedside manners have to be good, how when a patient comes to us, a relative comes to us, a patient comes to us, once we actually talk to them and once we actually explain to them what is happening, half their problems get solved. Their fears can be allayed. And if, yes, they have to go through some medical problem or the other. But when they actually meet us, and if our general demeanor is appealing to them, they feel much, much more comforted. And which is why the patient-doctor communication is very, very important. So what it does is really it helps to regulate the patient's emotions. It facilitates their comprehension of the medical information. So for us to get a good compliance, for the patient to understand why he's taking a particular medication, why undergoing an operative procedure, if he understands what is happening and if we are able to communicate that properly, he's more likely to be compliant and more likely to follow through with the treatment. I'm going to say he as a generic thing. It really means he and she. If the patient has better understanding of what is needed from him as well as what is to be expected from us, their treatment journey will be much more satisfying for them. So that interventions will give them more satisfaction. If they know what is possible for us to give them and what is not possible to give them. So for that, we require to have a very good patient-doctor communication. We have to not only tell them, but we also have to make sure that they actually understand what we are saying and what we are likely to, what is likely to happen during the process of their treatment. We are seeing that there is more and more litigation. We hear every day there is a newspaper flash saying that some doctor in some part of the country has been attacked again. We get physical abuse, we get verbal abuse, the nurses are being attacked, the whole hospital is being attacked. So all of these things would become less if we were able to communicate better with our patient and we could explain to them. So their expectations are not unnecessarily increased. So if they know what to expect, they also know what is going to happen in the next few days. And again, then they don't claim that we have been doing malpractice. They think that everything is, doctors are just out to loot them, they're just out to treat them badly. So if again we have good communication, we can then not be accused of being malpracticing doctors all the time. So there was a big study done by Sabarwal et al. At a Delhi hospital, in a private hospital, in a big tertiary center in Delhi, and where they gave 3,000 self-administered questionnaires to the patients who came to the hospital for treatment. And what was the conclusion of this study was that the majority of the patients were not well informed about their diseases. Up to 67% of the patients who answered the questionnaire felt that they were not told that what is the prognosis of their disease, what the treatment plan was exactly, and how the continuity of care would be continuing. So it is very, very important. Imagine 67% is a very large number. So we do need to not only give them information, but give them complete information in a language they can understand, information in a way they can understand. So these are very important aspects of communication. What also gives me hope in this number is that 33% felt that they were given adequate information. So it's not like it's not possible to do it. So I think we should really work harder at trying to give better information to patients in a language, in a manner, in that they are able to comprehend what is happening. There was a significant positive correlation when they said that communication at the initial stages of their hospital stay, right at the beginning, if the doctor had communicated or the nurse had communicated well with them, their stay in the hospital was better. So that was another thing that they mentioned, that made them much more satisfied towards the end of the stay in the hospital. And one of the main barriers they felt to physician communication was time. Yes, we are all very busy doctors. We all have lots of things to do. But it is really, really important that we find the time to communicate properly. So, what are the essential factors of communication? The biggest thing is that we have to have respect, right? So, when we have respect for our patient, then there will be a good communication with our patient. So, what is this respect? Respect is where we mutually understand each other's concerns and problems, and we can then have a good communication. So, what is the aspects of respect? First of all, it is very important that we develop a good rapport with the patient. When we develop a good rapport with our patient, what do you mean by that? What you mean by that is that you need to communicate with them, connect them at a social level, see it from their point of view. Yes, you know what is happening, but they have a point of view, and we must listen to their point of view. We must recognize that they have certain assumptions. Now, I know we are in the Google age. Everybody is going to read up about their disease and come. We are all, we as doctors need to know many things about many diseases. They have one disease, they're going to read up everything they can find about it, and they're going to become experts in their particular disease. And we can't escape that. And we must know that they are coming with certain assumptions. They know that oh, this is what should happen, that should happen. And therefore, we should first try to understand what it is that they already know or what they think they know, and therefore recognize that. And then, so that is what I call by getting a rapport with your patient. Already trying to understand what he already understands about his disease, what he may know about it, what someone may have told him about it, what he may have read up about it. So first develop that rapport, which will obviously be in the social context. We must have empathy. What is empathy? Empathy is a very, very popularly used word these days. Everybody is using the word empathy. But what does it actually mean? It is not sympathy. It is not having pity for your patient. It means that we understand why the patient is coming and from where the patient is coming. What is his behavior? What is that behavior coming from? So we acknowledge the feelings that the person is having. And that sometimes it becomes important to verbally acknowledge these feelings. Why are they behaving in the way they're behaving? So if they're suddenly anxious, maybe they have a very small illness, but they're over anxious about it. Or they are just too casual about it and they should be more anxious about it. So where is all this coming from? And when we try to understand that, that is when we are being empathetic. What do you understand by support? Support is that we help them overcome the barriers. Okay. So when we support them, they may have financial barriers, they may have barriers that half the family doesn't feel that they should be doing what they should be, what we have requested them to do. So all of these things we have to understand and support them through that, reassure them that we are always available for them, and thus build a partnership. We have to be a little flexible. I know that doesn't mean we just let them sit on our heads and decide everything they want to do. But at the end of the day, it is their life and it is their illness, and they can choose what they want to do with it. But we need to tell them what the facts are and explain to them what will happen if they don't have undergo the treatment or follow the advice. And thus that partnership where we try to show to them that, yeah, we are with you. We are not trying to be some sort of overlord that's trying to just tell you what to do. So this kind of partnership is very, very important to establish right at the beginning of our communication. Then we must explain to them properly what it is that is wrong with them and what is it that can help them, whether the medicine, whether it is surgery, whether it is physiotherapy, and how that thing is going to help them. Once we do that, and we often ask them, okay, did they understand what I'm trying to say? So you often check for the understanding. And then, depending on that patient's cultural beliefs, we will then go further and by respecting that person's cultural beliefs. So this is the respect module. And then by that, there's a T which has somehow not come onto this slide, but there's trust at the bottom of this. Only then will there be trust. And without trust, no good patient-doctor relationship can be achieved. And therefore, if you want that your treatment to have any benefit for the patient, trust has to be established. It's not moving my slide. Just a minute, we'll just move the slide. Okay, here it's come. Okay, fine. Okay, so all this requires that we should have good listening skills. We shouldn't just start talking, we should have good listening skills. When will the patient develop trust with us? When will he feel that we are empathetic? When will he feel that we are respecting him? He will feel respected when we have good listening skills. What are the aspects of good listening skills? We should face the speaker and make good eye contact. That gives them an assurance that, yeah, we know what we're talking about. We should be aware of their non-verbal clues. Are they looking very stressed at that point? Then you know that whatever you say is not going to go through. So give it a moment, make them relax, and then go back to explaining what you have to explain. Try not to interrupt them in the middle of what they're saying. When they're giving their symptomatology or when they're giving their concerns, try not to interrupt them. We should listen without judging immediately to the next step. Okay, he's told you he has a cough and you're already assuming he has asthma. No, we should listen to exactly what his symptoms are, because a good diagnosis comes from good listening. Don't start planning in your head what to say next. First listen to the complete thing that is happening. Show them that you're listening. So by that, you can ask them, or you can say, oh, is that what you mean? I hear that you're saying this. So stuff, sentences like this will make them aware that you are understanding what they're, saying, and that you're listening carefully. Always stay focused. If you don't understand something, ask questions. And many times it might be easy, a good idea to rephrase what they have just said. Say, okay, so this is what I hear. You have these problems, and this is what you're worried about. So summarize the whole thing, which makes a patient understand that you have heard what they have said and you've understood what they said. So that is what good listening skills are all about. And when you have good listening skills and you have developed a relationship of trust and respect for them, then you will know how best then to advise and counsel them. Then you will have come to some sort of diagnosis. Maybe you need to have some tests done. You will explain about the tests, and then you can start counseling or advising them. And when we try to counsel them and advise them, we must learn that we shouldn't be very complicated. We should try to explain it in as simple terms as possible. Be specific. Don't talk about this, that, and the other, or go round and round. Just be very specific, because they can't understand don't always discuss every possibility with them. You've come to some sort of conclusion. Be specific and tell them about that. Or you may repeat things because it takes them sometimes a little time to understand what's happening. Don't use medical jargon. Once in a way you have to, but if you are using it, then ask them if they've understood and explain it. Draw diagrams if necessary, and keep checking if the patient is understanding what you're saying. So when you have, I know it sounds like, oh my God, I have 100 patients sitting outside in my clinic and you're expecting me to do all this. But if you really want to be effective, if you really want that your patient should be compliant, be following up, and then not be, feeling that he's been treated badly. You must try to at least incorporate these. And once you get into the practice of this, it's not really such a hard thing to do. It just becomes natural, and your bedside manner or your way of communicating with patients just becomes a natural thing, and that will start making your interactions better with your patient. There are certain barriers to good communication. If you keep looking at your watch frequently, you keep appearing as if you're in a hurry, you look at your phone all the time, you use just medical terms and go away, you are talking in the ward with one hand on the doorknob, already ready to leave, your cell phone keeps interrupting, and you start writing a prescription and start examining even before you hear all the symptoms, then those are really going to be barriers in good communication. And if you ignore the concerns of the patient or the relative. So this is now something that I'm going to talk about how good, we talk about something called how to break bad news. It's often something we have to do. So I'm just going to talk about a scenario. Now you've seen this patient, he's been coming to you, you've finally done some tests, and now you have to tell the parent or a relative that, your results have come back. So the doctor's saying your results have come back. Your child has blood cancer and we need to start therapy. Okay. And the relative comes back to you and tells you, doctor, that is fine, but it's not so serious now. I mean, I think I've heard this so many times where after I've explained a long detailed thing about what's wrong with the child, the parent or the relative will ask me, but it's not serious now. So what should my response be? Should I tell him, have you not heard what I just said? Of course it's serious. Or should I tell him, I'm sorry, I've just explained to you, I'm in a bit of a hurry. My junior will tell you further steps. Or I think you should say, I hear you. What I've just said is not easy to take in. Let me help you to understand what this means. There are many new treatments available, and we are here to help with all the steps. I am sure many more questions will come up. Feel free to ask them. We can set another time when you have more doubts. So this is how really bad news should be broken. We're going to go through how we should share bad news or how we should have difficult conversations with our patients and their relatives. It is something, unfortunately, we have to do very frequently in our work. Yeah, we have never received any formal training for this. When I was doing a mental health training, it became so apparent to me that why aren't they teaching us this in our medical schools? But yes, they aren't teaching it to us, so we have to learn it now. And bad news doesn't always just have to do with death. It could be limits of viability. It could be long-term disabilities that you have to share with them. It could just mean that, now you have to change your lifestyle. I have to tell somebody you have diabetes, you can't eat sugar, you'll have to exercise. So it's a big deal. I mean, we take it very casually, but it's a big deal for that patient that the life, the way he knows how to lead it, has to change overnight now. Or they need a surgical procedure, or they have a continuing financial burden that we have to be, or there is actually something that is going to make them, need to face death maybe. So these are all very difficult situations and conversations that we need to have with patients and their relatives. It is also important as it's an extremely stressful time for the relatives, and their overall hospital experience would be shaped by how this sensitive news is communicated to them. Are we showing that we are caring? Are we showing that we understand that they're going through a tough time? And therefore, there is a certain mnemonic that has been come up, which is called SPIKE, which helps us to have steps of how and we should break bad news. So the first thing is setting up. So what are the goals? The goals are that we try to gather as much information as possible before we actually meet. So there could be something that is not within my purview. I am a general pediatrician, but this is a complex oncological condition. I may not know all the details about the oncological situation. So I would speak to my oncology colleagues and ask them what treatment possibilities are there, what is not there. So I should try and gather as much information as possible. And therefore, try to understand and also understand what the parents have understood already about it. You provide information according to the family's need and in the language. So sometimes, yes, there is a need that we have to tell them a lot, but we may sense that I can't tell them everything at the same time. It will be too much. It will be too overwhelming for them. So again, I have to sense that. So I have to get that sense of what is it that, how much is good enough to tell them at this point in time. We have to support the family, reduce the emotional impact, but we always have to be honest. We should never tell them false things. We can't say, nahi, nahi, sab theek ho jayega, sab theek ho jayega. That's not right. But at the same time, we shouldn't take away hope. So we have to practice how to do this efficiently. And there must always be a strategy and a management plan, which is already set in our mind before we even have this conversation with the relative or the patient. When you set up, what should you do? What are the things that you should take care of? Try to have the most senior most person in your team available because they probably have the most experience that would lead this interview. Inquire as to who would be likely to be present in the discussion. So which family members are going to be present, who are not going to be present, so that you have some mental preparation as well. Always have, when you're having this conversation, always have another person. Don't be the only person in the room of having the conversation with the relatives. Have another senior staff nurse or a resident doctor or a psychologist or anybody from the admin also present while you're having this conversation. Try to do this in a separate room, not over the bedside of the patient, because there are sometimes other beds or the actual patient is there and that may not be appropriate for that patient to hear. The ambience of that room should be soothing. Keep a box of tissues present so that if there is a breakdown, somebody's crying, it's available. You may need to have a recording device because sometimes, patients sometimes don't understand everything you say. Sometimes they claim that they haven't been told everything. So if you could have a recording device, that will be great. And then you must tell them that there is a recording device which is present in the room. Ensure that there's privacy, that people are not entering that room all the time, or try to make sure that we have privacy during this interview. As we said prior to the interview, collect as much possible information regarding the diagnosis, what new research is there, what available treatment options are there, what might be the side effects that they have to look for, so that if they ask us questions, we know all the answers already. Try to rehearse it in your mind for 5 minutes before you enter this conversation. Give your full attention. Keep the cell phone away and make a connection and introduce everyone around. So everyone should know who's present in the room. You should know who the relatives are. And even if the admin person is there, you should tell the relatives, this is the person who's sitting on. So this is how you set up to have difficult and really hard conversations. Try not to have them at the bedside. Then the next step is once you've done that, you try to perceive. Very important step. Try to perceive what the patient already knows and what is going on in that patient or relative's mind, and what is it that try to just ask some simple questions. How are you feeling today? How far have we come? Or what have you understood till now? Try to understand what it is that or they may say that, oh doctor, we're really scared of this interview, we're worried that what is going to happen in this, but what are you going to say to us? So try to get a little, just have a little conversation with them about, and therefore you will come to understand what the mood of the person is. How anxious they are, or are they relaxed, or are they, just clueless. So you'll get a sense of what's happening. So do spend a couple of minutes trying to get this perception in. Invite them. It's important to understand, how would you like to know this information? What would you like, where would you like me to start? So it is important to understand and know how best do you like. Sometimes it's not possible to have it in the room. You may have to do it on the phone or something. So ask them, would you like to come to the hospital? Would you like to do this on the telephone? Is there somebody else who needs to be on this conversation who's not there? Would you like them to be on a Zoom call, for example, or a video call? So all these things you should know, and you ask them, how much do they like to know us? Because sometimes they can't cope with too much information. So that's during the perception and the invitation process, we try to get a sense of how much can they handle. So invite them to tell us how they best want to be told about them. Then try to get the knowledge. Okay. So when you're imparting the knowledge, when you're trying to tell them what is happening, try to use simple language. Tell them the condition at their level. So you can't just say, oh, you have a this. You have to tell them, it is your kidney that is affected. There is a small tumor, or there is this and that, and try to tell them what is the kidney. Your kidney is the organ that purifies your body, makes urine for you. So all of those things you should try and tell them at their level. At this stage, we need to have this practice of the art of being honest yet hopeful. So you always have to be honest. You cannot tell them, a lie. You can't say, no, everything is going to be all right. Oh, the hospital is going to take care of all the expenses. Or we'll look into it later. Now, those kind of random statements should not be made. And yet, we cannot take away hope, because otherwise we take away hope, then they will just not want to continue with the treatment. And that's not going to be helpful for them at all. So this is a little bit of an art. This is what they call the art of medicine, where we know how to talk to somebody without being too honest, in the sense that you're just being brash and you say, you have cancer, you will die in 3 months. That's not how you talk about it. You have to tell them what is possible in the 3 months, or even if you think that it is terminal, what else can be done for pain relief for them, what can be done to make their life more comfortable. So all of that also needs to come into it. You can't just be very brash about the diagnosis. There's often a lot of guilt, especially for parents whose children are not well or relatives. And they feel that, oh, because I came too late for the treatment, this has happened, the cancer has spread, or, I didn't look after my child properly, therefore he's falling sick all the time. So we need to proactively sometimes tell them that this is not their fault, or this doesn't happen because of, XYZ, because they went on holiday somewhere, or, whatever. So sometimes we need to understand that, yeah, they're feeling guilty, and tell them, "Okay, this doesn't happen because of this. It's not your fault." And that gives a lot of reassurance to the relatives. And try our best to allay the anxiety without giving false hopes. That is how we tell them the knowledge. Now, this is the part where we have to be empathetic. Okay, so the empathy part where we recognize emotions. That is what empathy is all about: recognizing the emotion, observing it, acknowledging the emotion. So you have to tell them, yeah, I understand you're feeling sad, or I understand you're still confused, or I think you haven't quite understood what I'm trying to say, or this is very shocking for you. Would you like a few minutes to take in this information? So acknowledge the information, you label it. So you actually say, oh, you're looking very angry at what has happened. So sometimes you feel that the patient is feeling angry. Oh, my diagnosis got delayed because maybe some, hospital in the periphery or the village didn't pick up the signs early enough. So all these things we actually have to acknowledge the emotion by observing the emotion and acknowledging it. Then we kind of identify the reason for the emotion. You are angry because this happened, or you're feeling confused, this is too much for you to take, or you're in shock, you didn't expect this to happen and this is happening, or you're feeling really sad, or you're feeling guilty. So all these emotions we acknowledge, and then we try to give them a reason. Is this why you're feeling like that? So we try to talk around emotions. We should not run away from emotions. Many times we feel we're not adequately trained to handle emotions, so we try to avoid them because we can't deal with them so well. But that's something, as a doctor, as a physician, we must learn how to deal with emotions. So if you acknowledge them, identify them, and then validate them by saying that I understand that you're angry because of this, or I understand, and then comfort them for that emotion, whatever you think is culturally appropriate. So if it means that you can, you know, hold someone's hand, then that may be worth it. Or if you don't think that's appropriate, you just sit there and be there for them. So thus, then at the end, you have to strategize. Then at the end of the whole thing, after you've discussed the diagnosis, you strategize what is the following, what they need to do, what is the treatment, when, how often do they need to come for follow-up. Give them specific goals, and then therefore they can be have a further plan, and then you put this down, summarize it, and most important thing, do not forget to document it into the paper, in the files of the patient, because at that point the patient may be too upset and may not understand everything that you have said. Then they will feel that you've not told them, but at least once you've documented, you are also safe. And if you feel that the patient is not too upset, you can even ask them to countersign this document. But if you think that they're very upset at that point, it's okay. It's good enough for you to just sign that documentation. So these are some of the things that this is the way you should break bad news to anybody who is really needing to have some very serious discussions that needs to be had. Our next topic is going to be about how to deal with a situation where it gets very angry in any of the hospital scenarios. So I'm going to put up a scenario. You are delayed, you've been in an emergency, and you're 2 hours late for your OPD. All the patients are upset, they're fighting with your staff, and you enter and they start shouting at you too. So, what should your response be? Should it be that I'm sorry to have kept all of you waiting? I do know that all of you have taken your precious time to come and see me. I will see you all turn by turn. Or can you say, how can you fight with me like this? It's not fair. I wasn't exactly having a party. I was in an emergency. Or can you say that, those who want to stay, stay. If you don't have time, you can go back home. So obviously, the second two statements are not right. At the same time, what are you exactly saying sorry for? You're not saying sorry for the fact that you were stuck in an emergency, but you're saying sorry and that you're appreciating the fact that they were all waiting, that their time is also precious. That's all you're acknowledging. You're not saying sorry for the fact that you are a doctor and that you were stuck in an emergency. So that is what it is important to see what it is that you're saying sorry for exactly. But there is absolutely no harm in saying sorry. So we often see that this happens, right? This is on the increase. Patients are destroying our property, they're attacking us, and we have to learn how to prevent this, because the cure is really not, taking legal action. Yes, we're all fighting for legal action to be taken against patients who are, misbehaving with us. But at the end of the day, we have to actually prevent it rather than cure it. So how do you diffuse or manage an aggressive situation in a hospital setting? So we try not to let it get to that stage. But if you're associated with an institution, you should actually lay down a plan of who will diffuse the situation, how to call for help. So you must always have a plan that has been practiced regularly, that can make all the difference. So which are the people that are going to come and diffuse the situation when somebody seems to be, imminently violent. If this is happening, then first thing you have to do is actually, if you think somebody's really going to attack you, harm you, you need to get your patients and your staff have to be first of all made sure that yes, that is the priority. But if you think that this patient is upset, shouting, but not yet reached the stage where he's going to start attacking you with some sort of instrument, you can use the diffuse protocol to actually help to diffuse the situation. Okay, so let's go through the diffuse protocol. So first is you take this 5 seconds to decide, is this appropriate for verbal communication or not, or do you need to call for help? And we all, in a hospital setting, we must have ways in which we can call security quickly, or police help can be called quickly. So we must have that kind of security measures put in place in every institute that we are working at. If you think it is possible to diffuse the situation with verbal communication, then you consider going in and trying to talk to the patient to help with the situation. So once you've ensured that then you start ensuring that everything is safe. Make sure that there's backup coming in case the things get worse. Clear the area of potential weapons. If there are things that they can be attacked with, we have scissors, scalpel, all these things lying around. We clear them all off. So that everybody's personal space is respected, and nobody can get attacked. Then introduce yourself. Say that you are whoever you are, the senior consultant or somebody from the administration or the manager or even just the resident doctor, whoever it is. Introduce yourself and ask them what they want to be called. So already when you start having conversations and you're starting to give them that little respect, what would you like to be called, Mr. So and so, Mrs. So and so, they start coming down little by little by little. So start having conversations with them to see that you make a nice social relationship with them. You acknowledge their feelings. Okay, you can't deny that. Oh, how can you be angry? You can't say something like that. You first have to acknowledge that they are angry, because if you say how can you be angry, you say I don't know, I am angry. So first say I understand you're angry. Let's see why you're angry. Okay, and I'm sorry that you're feeling like that. Again, what you're saying sorry for is not whatever that has caused the anger to happen, without understanding what that situation was that caused for that person to be angry. What you're saying is that I'm sorry that you feel like that. So that's all you're saying sorry for. But the word sorry calms them down completely. And then you start understanding, tell me what the problem is. Tell me why this is happening. Why is it that you're feeling angry? Once you start engaging them in conversation, they will start calming down. So start with that. Utilize, okay, oh, so you've been delayed, or something else has happened, or the wrong treatment has been, you think that the wrong treatment has been given. Why do you think the wrong treatment has been given? What makes you think that? So things like that, so already you don't accept that there's wrong treatment has been given. You start asking them, why do they think that wrong treatment was given? So try to be little, make it still that it is under investigation. It is not a done deal. Then, if they still don't talk to you in a calm manner, you start having to say that, I'm sorry, I'm trying to help. But if you're going to keep shouting, I can't speak. You have to set the limits. Okay. You have to tell them if you need to, you need to keep shouting. And if you're going to be violent, then I'm very sorry. I can't help you. No one can help you. We're going to walk out of here and you can, we'll get security to, take you away. But if you want us to help you, please let us help you and tell us what we can do to help you. So offer reasonable choices. Do not offer them something that is not possible to do. And then keep repeating that till they hear. So that is how you can diffuse the matter. And you said you be firm. There's no need to be like, completely, oh, please, 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 please. Be firm that this behavior will not be tolerated. We are willing to understand what your problem is. But if aggression then escalates and you think violence is imminent, you withdraw and you look for security or police help immediately. So that is the diffuse protocol for any situation that becomes aggressive in a hospital setting. So what I want to say at the end of all of this is that that it has been found by studies that 90% of situations that become aggressive are really because the proper communication was not established in the first place. If we, and I'm not trying to say that we don't want, we're hiding things from people, but some of us don't often tell all the details. If we know how to talk and how we can tell them what is there to expect. Sometimes patients come with very, very high expectations, and we don't have to always, be listening to them. But if they are told right from the beginning what is expected and what is going to happen down the line, that these situations where they will become aggressive are less likely to happen. So good communication will prevent abusive behavior. Because people forget what you said, people forget what you did, but they never forget how you made them feel. So make them feel important, make them feel respected. Respect is the key word over here. And how do you make people feel respected? We've already gone through, where we are listening to them here, where we try to be empathetic with them. So if you make them feel that they are being cared for, they will, first of all, comply better with us, and they're less likely to get aggressive against us. I thank you for your patient listening. And I'll invite you if there are any questions anybody has. Or
Yes, anyone has any questions, you all can please ask ma'am, or even if later put it up in the chat box. So I really thank Dr. Bela. He taught us about the respect model for good communication, the spikes protocol about how to share the bad news, and of course the diffuse protocol to handle the worst case scenario. Thank you, Dr. Bela.
Thank you very much for inviting me.
So our next speaker is Dr. Zubin Pereira. Sir would be talking about interpersonal communication amongst healthcare workers. Dr. Zubin is the facility director of NHSRCC Children's Hospital. He has completed his MBBS and MHA with a total experience of 19 years in the industry, with 15 years at SRCC Children's Hospital. I welcome sir.
Good afternoon, everyone. And thank you, Dr. Rojul, for giving me this opportunity to make a small presentation on effective communication. So, see, in a day-to-day environment in the hospital, there are multiple people who a patient interacts with. Um, Assuming that a patient stays in the hospital for about 3 or 4 days, there are so many people that the patient meets: doctors, nurses, technicians, housekeeping, security, maintenance, etc., etc. And all these people have a role to play in the hospital. They have a role to play with the patient, and it's important how each one communicates to the patient. A lot of problems in the hospital can be avoided if there is good communication. A lot of discomfort of the patient can be avoided if there is good communication. Very often, it so happens that obviously, the patient comes to the hospital for medical treatment. The medical treatment is taken care of, but if there is anything that provides a bad experience to the patient, it is the other non-medical aspects of treatment. So if say your AC in the room was not working, or if the bathroom has not been cleaned, or if housekeeping takes time to shift the patient from one place to another, these are the things which spoil the atmosphere or spoil the experience for the patient. And the patient, when they leave from the hospital, they leave with this impression that their stay in the hospital was not good enough, was not comfortable enough, only because of all these issues that happened. And all this boils down to the fact that if at all the communication could have improved between healthcare workers and the patient, a lot of these problems would have been solved. So what can go wrong if there is no communication, or if there is improper communication? Safety of the patient is at risk. Say the delivery of medical care is at risk. The movement of patients across the hospital is at risk. The whole process of say discharge is compromised. So these are the things which can go wrong if at all there is improper communication. Now, we would see that according to the Joint Commission International, which is an international accreditation body for hospitals, and our hospital is also a JCI, a Joint Commission International accredited hospital, they have stated that medical errors are amongst the top 10 causes of death in the United States. And United States being so organized, you can imagine that if in United States in the top 10, probably in India, it could be in the top 5. Because there are a lot of gaps that even we have here in our hospitals, no matter what how good or how bad a hospital is, there are always gaps, there are always delays in treatment, there are always errors in treatment, which can cause morbidity and in some cases mortality as well. So what is it that we use in terms of communication? So here at our hospital, we have a system called S-bar, which talks about the situation, background, assessment, and recommendation. So basically, this is a system where we use to hand over the patient from one shift to another. If at all the nurses are looking after the patient, the doctors are looking after the patient. So what information is required to be passed on to the next shift? This is important so that the next shift, the incoming shift, or the staff of the incoming shift, they are aware of what has happened previously to the patient, and on the basis of that, they continue with the treatment. So all hospitals have got a handover system wherein nurses give their handover, doctors give their handover, technicians give their handover, paramedicals. So there is always, and as all of you are aware, hospitals work round the clock. So there are always at least 3 shifts running in a hospital, morning, evening, night. But it's not the same people who are working throughout the day. So the people keep on changing. So obviously from morning to evening, evening to night, night to the next morning, there has to be a transfer of information. So these are some of the points that we have in communication. It's called the 7 C's of communication: completeness, clearness, conciseness, consideration, concreteness, correctness, and courtesy. All the points are self-explanatory. There are little explanations for all of them. But basically, these are factors to be taken into account whenever you are passing information about the patient's medical status, or about the patient's health status, so that there is appropriate information and there are no gaps in understanding what is happening to that patient. So that was a little bit of theory that I shared with all of you. I'll just now talk to you about a few scenarios which have happened in our hospital in the recent past, but these are things which could have happened in any other hospital as well. So that's not something unique only to our hospital. And these scenarios would highlight what better we could do to resolve the situation. So we have a situation where a patient comes to the radiology reception at 12 p.m. for a CT scan. And they wanted the appointment on the same day. They are told that due to a packed schedule list, the same day appointment is not possible. But since they've come all the way because they came from out of Mumbai, they wanted it on the same day, and eventually they were given an appointment at 5:30 p.m. But they felt that 5:30 was too long to wait. And they were upset, obviously, because the staff at the hospital had told them that it's too long to wait. And the referral clinician had said that this is an urgent scan. So if it's an urgent scan, how can they wait for till 5:30 in the evening when they are in the hospital from 12 p.m.? So how could we have resolved or addressed this situation? I think this is a situation that could have been managed better by us. To begin with, it's not only with us, but in any other center, CT scans do not take much time. CT scans happen in about 5 minutes. An MRI may take 45 minutes or 1 hour, but a CT scan is much more quick. So we could easily have adjusted this patient for a CT scan, maybe not at 12 o'clock, but say maybe at 1 o'clock or 1:30. Secondly, probably the staff over here did not even speak to the radiologist to understand the urgency of the scan, whether that scan could have waited for 5:30 in the evening, or because they had their schedule, they saw that, okay, there are no slots and the next slot is only at 5:30, we will give you an appointment at 5:30. It's very much possible that the radiologist wasn't even aware that the situation was happening outside. If at all the radiologist was aware, probably he or she would have intervened, would have understood what the case is, and would have taken a call of taking up this patient earlier. So this is something that could have been addressed and would have given a better experience to the patient. Another radiology related scenario that we saw is this patient is undergoing a CT scan, but the radiologist feels that an MRI would be more helpful. He goes ahead and does the MRI scan. But the parents, when they go back to their primary consultant, to their referring physician, the primary consultant says that, why was the MRI done? I asked for a CT scan. Why was the MRI done? So then there becomes a small conflict. So here, probably what could have been done is the radiologist felt that clinically the patient needed an MRI. Either the radiologist or somebody from the radiology department could have phoned the referring physician and said that, given the situation, the radiologist has advised an MRI scan instead of a CT scan, and therefore we are doing a CT scan. We are doing an MRI scan. Probably this would have gelled better with the referring physician. He would have felt part of the whole process, and he would not have taken offense or objection to the fact that he was not consulted when the test changed. So here again, there was a gap on the side of the hospital where if they had taken the initiative to communicate better, probably they could have addressed or managed the situation better. So what happens very often is all of us are busy with the things that we do on a day-to-day basis. We don't really make the effort to try and reach out to people, to try and proactively resolve a situation. We may feel that this is not my job, this is somebody else's job. Now, no doubt that some things are to be done by others. Like a nurse will only do nursing related things and a doctor will only do doctor related things, no doubt. But there is always something that a nurse can do which is not within her purview, or a doctor can do which is not within his purview, or say a front office person can do which is not in his purview, as long as it's in the best interest of the patient. So that is something that we should always keep in mind, that at the end of the day, it is a patient for whom we are all working, and it's the patient's comfort and the patient's satisfaction that we are all working for. So here there is a new one more situation. A surgeon comes for rounds post-operatively and decides to check the dressing and suture removal and request for a staple removal. The nurse in charge has to send the housekeeping to get a stapler removal from the CSSD. That takes time. The consultant gets impatient and leaves without stapler removal, asks the RMO to do it. In the meantime, the RMO gets busy with some other work and the staple removal is delayed by 2 or 2.5 hours, and the patient and relatives get agitated. So here, how could we have managed this situation? I think to begin with, if we anticipated that a staple removal needs to be done, we should have had the material ready for the staple removal there by the bedside, so that if the consultant comes, he can immediately do it. If for whatever reason the decision was taken there and then to do a staple removal, and there is a possible delay in getting the instruments, perhaps the consultant could have told the patient that he has to leave, but the RMO would do it. I think in this case, what happened was this information was not given to the patient that the consultant is getting late and he is leaving, and therefore somebody else will come and do the staple removal. The consultant just left from the picture, and there was no proper information about who is going to do this procedure. The RMO also got the information that he needed to do this procedure a little late. During that time, he was already occupied with something else. So if all this had been communicated and had been told to the patient that, okay, consultant has to leave, he cannot wait, but the duty doctor will come and do it. He may come in an hour's time, he may come in 2 hours' time. At least the patient is prepared for it. And even if that 2 hours becomes a little more, the patient knows what the plan is. Here, the patient did not know what the plan is. He thought that because the doctor had left, probably the suture removal was not going to be done or would have been done the next day. And that caused an unpleasant experience for the patient. A fourth scenario, 26 weeks, twin preemies are admitted to the NICU post-delivery. The condition of one of the twins worsens and unfortunately the baby dies on day 4 of life. The second twin is stable. The obstetrician complains to the management of the hospital that he or she was not informed about the death of one twin and is concerned since the relatives are creating a ruckus in the private clinic. Now, here what exactly happened was the referral, the obstetrician, yes, was not informed, but the pediatrician who was managing these cases was very much aware of what was happening. And the assistant of the obstetrician was also informed of the situation that one of the twins had died. And the assumption of the NICU staff was that if the assistant has been informed, the assistant will inform the obstetrician. Now, what happened was probably the assistant did not inform the obstetrician, and the obstetrician was unaware that one of the babies had died. And then after there is an incident like this and somebody is asking questions, then when we say that no, we informed your assistant, the pediatrician was aware, then it looks as if excuses are being given. So probably just as a proactive measure on this part of the NICU, and this is something that we've incorporated ever since, the NICU doctors do inform the obstetrician as well, the main obstetrician of the patient, as to what is the status of the baby in the NICU. If there is improvement, if there is worsening of the situation, if there is some adverse situation that has happened with the baby, intubation, extubation, whatever. So now we've decided that we will keep the primary obstetrician informed of the same. And the last situation is a spinal case is scheduled for 12 p.m. and it's delayed till 2 p.m. and it is still uncertain as to when the surgery will happen. The child and parents are anxious because the child is fasting since 5 a.m. and there is no information given to the patients, to the parents of the patient as to when the surgery is likely to happen. And what happened was the same surgeon was involved with another emergency case earlier, and that emergency case was still going on. So how could we have addressed this? So here I think it is a very straightforward thing. Somebody from the OT should have communicated to the patient that there is another case going. Your doctor is occupied and preoccupied with another surgery, which is an emergency. And that's why there is a delay. And your surgery, instead of 12 o'clock, is likely to be at 2 o'clock or at 3 o'clock. I think this is a very simple thing that could have been done. That was not done. And again, the same reason why it was not done, it's because it was expected that somebody else would communicate to the patient, to the parent of the patient. So when we keep on expecting that somebody else will do the job, when we can easily do it ourselves, is when these gaps in communication arise. So in all these examples that I have discussed with you, multiple people, multiple departments are involved. But what is important is if we can just be a little more proactive, a little more cooperative, get out of our silos, do a little more than what we are supposed to do, a lot of things can be addressed. If at all, if at all the patient leaves from the hospital happier than when they came, that means that our job is done. Not only from the medical point of view, but from the comfort point of view. So these are just a few things I wanted to discuss and put forth before you. As a hospital administrator, this is what comes to me on almost on a daily basis, and we need to address these points. And so these are some experiences that we've had that I thought I would share with all of you. Thank you.
Thank you, Dr. Zubin, for this very practical and hands-on scenarios and the best ways to handle them. Any questions, any doubts anyone has, anyone wants to ask any questions, you all can ask. And also put it up in the chat box. And in the meanwhile, I'll introduce you all to our next speaker, Dr. Suganti Iyer. Madam will be talking about the medico-legal aspects of documentation, certificates, and mishaps in clinical management. I'll introduce ma'am. So ma'am, after completing her MBBS from St. GS Medical College and KEM Hospital, Mumbai, she has a degree in law from New Law College, Mumbai, and a degree in clinical research and insurance. Ma'am is currently with Hinduja Hospital, Mumbai as the director of the legal and medical. She's also visiting faculty in the law at University of Mumbai and Tata Institute of Social Sciences and other institutes. She's an NABH principal assessor, a trainer for NABH workshops, and has contributed to 2 books on medical negligence. She has participated in large number of workshops on medico-legal aspects and contributed to publications pertaining to legal aspects of healthcare. Her area of forte is legal and medico-legal. She's also associated with medical audit, quality and accreditation, insurance and hospital administration, where she has an experience over last several years, and has been a convener of Medico-legal cell of the Indian Medical Association Mumbai branch for the last many years. I welcome ma'am.
Thank you so much for the kind introduction. I hope my slide is visible.
Yes, ma'am, it's visible.
Thank you. Thank you so much. So thank you first, SRCC, for inviting me as a speaker for this online program. My introduction, thank you for the kind words. What I would discuss today is about medical certificates, medical mishaps, and also documentation aspects for doctors. So medical certificates, that is the first thing. So what is a certificate? A certificate is a document, and it is not just a document, but it is a legal document. It is a legal document, for it can be presented in a court of law, and the doctor can be called to give evidence on the certificate. And what is important is that what has to be stated in the certificate has to be the right thing, for since it is a piece of evidence, if something erroneous other than the truth is written, then it becomes something false, and then it would become as if a false evidence is being filed by the doctor in the court of law. So when we say a certificate is false, we mean that you will commit the offense of giving false evidence, which was in old IPC section 191, and then you could be then hauled up for that section where you are giving false evidence in a court of law. The other offense is that of forgery. So if you give a false certificate knowingly or unknowingly, when we say unknowingly, it merely states that you have to verify the facts before you write the certificate. So the second offense that will be committed by the doctor who has written something improper would be forgery. So that is the side effect of giving a certificate which has not been verified by the doctor. So therefore, what are the essentials of a medical certificate? The essentials of the medical certificate is that it has to be issued on the letterhead of the doctor or the letterhead of the hospital. And if it is that of the doctor, it has to contain the qualifications as per the Code of Medical Ethics, the registration number, the name of the doctor, and the signature of the doctor is very important. It has to be restrained to that period of time for which the doctor is giving certificate. It has not to be even one day before or one day after. And it has to state the facts as mentioned before. And also very important, to prevent impersonation, it is very important to make mark the identification marks and note it down on the medical certificate. Generally, 2 persons or more, or less than 2 persons, no second person will bear the same identification mark. It is very important for if there is somebody else coming with the same name and borrowed his Aadhaar card, borrowed his voter ID, just to show that they are present. It's the same person, but identification mark which is unique and not the same to two different people. No two human beings have the same ID marks. Please write the identification mark. In addition, as is the concept of the present Prime Minister Modi, mention the Aadhaar number also on the medical certificate. Now, very often, I will tell you examples of false certificate. For example, while doing a pre-employment medical checkup, once one person had come into the doctor's clinic for fitness. That person had a sore eye. And the doctor said, what is wrong with your eye? So he said, I'm having some mild conjunctivitis, I'm putting some eye drops, etc. Later on, after the employment, the doctor was called upon as to why he gave a fitness certificate pre-employment. And then that the doctor had given a fitness certificate to somebody with an artificial eye. Therefore, it is very important that the doctor check the person, and it is considered as a false certificate. It means you have not examined your patient properly. You can't just trust a patient saying that he has sore eyes, conjunctivitis, etc. You should have done a proper examination of vision eye by eye. The second thing, which is a true fact, which has happened now. In fact, all the examples that I would be citing are the true cases. In one case, a patient who was a regular patient of the doctor walked into the clinic and said, I want an under treatment certificate that I had come to you, doctor, about 2 years back. And I was under treatment from this day to this day for some dysentery. And please give me the certificate because my employee, some gratuity, some provident fund, some arrears are there. And I need the sick certificate. It is regularly showing absent. So therefore, the doctor said, let me check up my medical record and give the correct dates. But however, in the short time that he wanted urgently, there was a huge pile of records to be checked. And the doctor assumed, yes, this is my regular patient, I trust you. So he gave the certificate, and that from so-and-so date to so-and-so date, this patient has come and been under my treatment, though he had not verified with his own medical records. Later on, he was summoned to a court of law, and he was told that he was hauled up in a court of law saying, doctor, the dates which you have mentioned from so-and-so to so-and-so is a period when this person was in jail, and he was in jail for an attempted murder. How come that when the person is in jail, you have given a medical certificate? Of course, the doctor was in deep trouble. They were about to remove his name from the medical register. He had to struggle a lot. Finally, there were people who approved him, and then he got out of the case. But let me tell you that one has to state the facts. Please verify the records before you give any medical certificate. So this is what we need to do before getting medical certificate. And always the last thing is that keep a duplicate certificate with you for your records. For if you give the certificate which you have issued, they could be definitely the tampering. You may say rest for 2 weeks. The person can add a 0 and make it 20 weeks, or add a prefix of 1 and make it 12 weeks. And you may not even know later on the Xeroxes and the way the people tamper it appears as original. Therefore, always keep the original. Remember, this medical certificate is a medico-legal document. Anytime you can be called upon in a court of law to depose upon it, and therefore, please keep a duplicate of the medical certificate. The types of medical certificate is number one, the birth certificate. When a person is born, he is given a birth certificate, son or daughter of Mr. So-and-so, or so-and-so is the mother's name, and the birth register is a permanent register. So this is the birth certificate. The age certificate. Sometimes we get the dead bodies. We do not know what is the age of the dead body. So they may need an age certificate which has to be given by the post-mortem doctor who examines the hair, the nails, the bones, etc. and gives the age certificate. The third is the most important, which we do on a day-to-day basis, the under treatment certificate or the sickness certificate, the fitness certificate and disability certificate. So the treatment from which period the patient has come to you up to which period the patient has taken the treatment under you. Please mention the first date and last date as per what you deem fit, as per what the patient has presented in front of you. Please, for the sake of just making the patient happy, or for the goodwill or retaining a patient, as today is the case, do not make any day extra. For you do not know, one day prior the patient was in jail or he had committed some crime or whatever is the reason. Be very, very careful. Fitness, give it as it is. And disability certificate. Now, this again, I would request you to be very careful. There's another case which I can cite where the patient who had a stiffness of the 4 fingers went to a particular orthopedic surgeon. He had actually undergone a surgery from another orthopedic surgeon and left with a residual disability of about 5%. So he wanted to get rid of it and he went to the orthopedic surgeon who also involved a plastic surgeon, got reduced the disability to 2%. And at the time of discharge, he was giving a certificate. At that time, the patient approached the doctor, see doctor, that if you give the certificate that I came with 5% and discharged with 2%, but my insurance, I got an insurance of 4 lakhs. Insurance will not pay me. They will pay only if I have come with a disability or discharged with a disability of 20% or more. Now, if I don't get the money, how do you pay your fees? Your fees will be decreased. I can pay you more fees if you give me a proper certificate that my at the time of discharge, if disability is 20% at least. So the doctor did not understand. And then in good faith, he said, came with a disability of 5%. At the time of discharge, after the surgery, patient was discharged with the disability of 25%, thinking the patient will get 4 to 5 lakhs and give him a huge sum of money. What he got in return is a summons from a court of law saying that you have been hauled up and you have been negligent in your surgery because you have made 20%, 25% disability from one who came only 5%. And you can imagine the torture the doctor had to undergo and then also pay the compensation. So therefore, be very careful when you deal with the disability certificate. You have the schedule under the Workmen's Compensation Act, which is very obvious. So be very honest with your certificates. Do not try to make your patients happy or retain your clientele. Be honest to yourself and do justice to yourself and see you do not get into trouble. Vaccination certificates are given when patients are going abroad. Your influenza, pneumonia, measles, yellow fever, so on and so forth, that you can please issue. Dangerous diseases like leprosy, of course, we had tuberculosis, AIDS, so on and so forth. We have to give the certificates when they are suffering from dangerous diseases like this. Please issue it. Certificates of lunacy are very important. When we say lunacy, a person is not in state normal mental capacity. Now, as you know, when we have to give the consent, we have to take from an adult person who is above the age of 18 and who is mentally sound. This is very relevant, especially when you take the consent. So from for consent point of view, patient has to be mentally sound. Sometimes patient is in a stage of delirium, patient is in a state of encephalopathy, etc., where they cannot give the consent. But one has to get it ascertained by a neurologist or a psychiatrist that patient is in a proper mental state of mind. Now, the requirements of the THOTA or the Transplant of Human Organs Act clearly states that an organ donor has to give the consent. And this is one of the essential requirements, and that the patient is mentally sound has to be certified by a psychiatrist. This is the rule as per the THOTA rules. So therefore, since consent has to be given, now say signing of a will, giving a will. Now that is important. When a person writes a will, he has to be mentally sound and not under coercion, undue influence. So again, a doctor has to certify that the patient is in mentally fit or mentally sound to sign a will. So giving consents, will, etc. Additional certificate is required by a doctor to give mental fitness. So this is of utmost importance. Death certificate. This is somewhere where everybody lands in a dilemma, and this I want to take some time. Now, when you give a death certificate, what are the most 2 important things? The first important thing is that you have to ascertain the person is dead. Why I'm saying this is that very often we see in the newspaper that from the mortuary, the person got up and he climbed up, walked out, or from where they went to do the cremation, and about the funeral pyre was about to be lit or buried, and the person gets up. Why this happens? Because this happens especially maybe not in 3-tier, 1-tier cities like us and in top 5-star hospitals like where we work, but maybe 2-tier or even the remote villages where the person is in coma or the person is in a state of encephalopathy, etc. They have not diagnosed, and they take it for dead, and then the person, then suddenly the person wakens up. So therefore, one please has to certify, and the requirements is that at least 2 registered medical practitioners have to certify, yes, the person is dead. You can conduct your various tests, your EEG, your ECG, your pupil sign, etc., etc. Please confirm the proper death if you're not sure of the death. Number 2, about the forms. In Mumbai, all of us are here in Mumbai, we have Form 2 and Form 4. One of them is a cause of death, which a doctor signs. And how you fill the cause of death? Immediate cause of death. Immediate is say, for example, you have the hemorrhagic shock due to rupture of the esophageal varices, due to portal hypertension, due to liver cirrhosis. So you have immediate cause of death due to what? Then the antecedent cause, then associated causes. So you have 3 columns. So cardiorespiratory arrest and brainstem death are never the cause of death. They are the modes of dying. Because when a person dies, everybody in the end dies of cardiorespiratory arrest. That is a mode of dying. Very often we see the doctor certifying as the cause of death. So respiratory arrest, I understand. Respiratory failure, I understand. Where in chest conditions, ILD, etc., you can have the respiratory failure. But CR arrest is a mode of dying. Brainstem death is a mode of dying. So take the immediate cause of death. For example, you have this, if there is a cancer, malignancy, you have the secondary, say, in the bones, and that leads to a fracture. And then after that, the person gets a pulmonary embolism. So immediate cause of death is pulmonary embolism due to the fracture of the femur or any other bone, due to the secondary is deposited, due to the primary carcinoma. Then you have your other associated old age, hypertension, diabetes, etc. So this is the way the forms are filled. In the other one, they only the date, name, and all the details of the patient are sent. In fact, the patient is given only the acknowledgement of the form number 4. The other 2 are sent to the authorities. In Mumbai, we send it to the Bombay Municipal Corporation, and then the certificate, after the crematorium, the BMC gives you the death certificate, the number of copies that you want. So one has to be very careful and write your registration number, etc., the hospital, your clinic names, etc. So be very careful while filling the cause of death, because this is final and this is registered in the death certificate. The address, etc., name, tell the relative to fill carefully. Once it is given, I'm not saying it is impossible to change, but they have to undergo with affidavits and so many other, and BMC is not a very pleasant thing to go again and again, you see. So have some sympathy for your patient, tell them to write the proper name, etc., etc. So now, what is very important to note is that the death certificate or the cause of death certificate that you give, and then they give the death certificate, is again a medico-legal document, and you can be cross-examined in a court of law, especially in the case of litigation. If you are given a cause of death, you will be asked as to why you gave this as a cause of death. So number 1, issue a cause of death certificate only if you can have the supportive documents to support the cause of death. You have to substantiate the cause of death that you have given in the death certificate by means of evidence in a court of law. It is a medico-legal document. So the cause of death, suppose you write bronchopneumonia, respiratory failure, you should have your X-rays or CT scan or something else saying that. So you need the evidence. So any supportive evidence, if you say myocardial infarction, etc., cardiac arrest or whatever it is, you should have your raised enzyme, you should have your ECG changes, etc. So therefore, when you say septic encephalopathy due to chronic renal disease, whatever, you should have all the biochemical parameters. You should have your diagnostics in place, your medical records in place, and your treatment parameters, everything to show, yes, the person had this disease. You can be hauled up. If there is no supportive evidence, please do not issue a natural cause of death or a death certificate. Please hand it over to the police. Very, very important. In Renu Jain versus Escorts Heart Institute, it clearly states in which case you can issue a death certificate and which you are not supposed to issue a death certificate, but release it to the police. You can issue a death certificate, as I said, only if you have it's a natural cause of death and you have the supportive documents for the supporting the cause of death that you're going to certify. Now, in this judgment, it is said that if it is a police case, that means there is something foul, do not issue a cause of death. If there is a death on the OT table, on the procedure table, dialysis, while undergoing MRI, imaging, barium swallow, etc., any procedure, do not issue a cause of death, or in while undergoing a blood transfusion, etc., do not issue a cause of death. It means there is something that has happened, mishap has happened. So it has to be, there has to be no cause of death. Immediate post-procedure, immediate post-operative period. If it is very stormy and the patient dies after some time, within 24 hours, and that means, again, it is very difficult to explain this. Therefore, do not issue a cause of death. Also, if the patient has not adhered to your line of treatment, you must have advised diagnostics, you must have advised medication, they would have refused, they would have given you a refusal of consent form in the hospital. If they agitated relatives questioning you, if they are lawyers in the family, etc. Also, in the case of sudden death, you go for rounds and you're about to discharge, and just suddenly one day the patient drops dead. No, you're not issuing if it's a sudden death. We do not know what has gone wrong. So in such cases, in such and similar instances, wherever you feel there is something foul, you are not sure of the cause of death. Just a simple thing, the patient may be admitted under you for 3 to 4 months, but you cannot come to a diagnosis. You are not sure of the cause of death. Just do not issue the death certificate. As simple as that. Refer it to the police. So these are the times where you should not issue a cause of death. Just hand over to the police. And when you hand over the police, there are 3 forms. Form A, Form B, Form C. In Form A, what happens? It is if you feel that death is natural and you can give, but it is not under normal circumstances. Death on the OT table. Okay, you're taken for CABG. You have the angiography to support. Yes, there's a blockade. Yes, some patient had a low EF. Whatever it is, cardiomyopathy, etc., the patient died, and you want to certify, but it is on the OT table, or immediate post-operative within 24 hours with a stormy post-operative period, patient has not been stable. There you can fill Form A. You may give, say, suggested form of death, but then hand over to the police. They will give a NOC, no objection certificate, and then only go ahead. So it has to go to the police. Now, Form B, if it's an unnatural death, again, refer to the police, let them do a panchanama, let them decide. Okay, if the relatives may give the police station affidavit where they don't suspect foul play, the police ultimately decides, yes. In Form C, where you're certain that you just don't want to issue the certificate and you have to hand over to postmortem, just fill Form C. So we have the various forms which are available. The police and BMC has made it available. And it's not compulsory for you to just make the relatives happy. For relatives today will beg of you to give the DC, but once the ashes, before they turn cold, from the hands from falling, if you're holding your feet for death certificate, it will go up to your neck and strangle you and litigate you, pull you in a court of law, saying that the person has been negligent and that is why my relative has died. So just don't be emotional, be practical. So that is the first thing. In Aruna Bain versus Navdeep Nursing Home, where a patient had a fracture femur and the patient died during surgery, and to alleviate the trauma of surgery during the death of the patient during surgery, relatives asked the doctor, please issue a death certificate. We'll give you in writing a consent for waiver of consent for postmortem. Please issue death certificate. Already you have undergone a lot of mental trauma, and the consultant obliges by taking a writing that they don't want PM and issues a death certificate. In less than a month, he gets a notice that the relatives have complained that he has been negligent, and that is why the patient has died in the OT table. And when the hearing comes for a case comes for hearing in the court of law, and the doctor says, see, they have given a waiver of consent for postmortem, they didn't want, that is why I give death certificate. Hence, and the commission pronounced the order that what you need is to uphold the law. The law says if the patient dies on table, you have to give for PM. So waiver of consent is not legal. The law is supreme. You cannot take a consent or a waiver of consent against the law itself. So when the law says that death on the table, immediate post-operative period, medico-legal cases, you have to inform, you have to hand over the body for post-mortem or inform the police. Waiver of consent for PM does not arise and is illegal and null and void. Next case, Satyanarayan Agarwala versus Alka Goswami, wherein the young lady, 32-year-old healthy patient, walks into the operation theatre, climbs on the OT for a hysterectomy, and later on a dead body is handed over to the relatives, stating that the patient became breathless. Suddenly, there was a sudden cardiac arrest and the patient died. Now we take a relative home and we're issuing a death certificate and pulmonary edema is written. And then they're very, very unhappy. They go to the crematorium. There is a gauze pieces soaked with blood where the incision was taken. The mortuary keeper also says, at the crematorium, people say there is something suspicious. And again, the relatives come back saying, we don't accept this. We want a postmortem. The postmortem is done. And ultimately, when the case paper is also, remember during postmortem, the entire case papers, hospital papers have to reach the PM doctor who goes through everything. And then they realize that the monitoring during anesthesia was not done. The patient was initially 99 SpO2 and suddenly drops to 60 SpO2. The anesthetist has not monitored and the records were very clear. Suddenly the patient has become cold and blue and there was a hypoxic brain damage and also the patient has died. So, and therefore the doctors were told negligent, not only for negligence itself, but also for issuing a DC and hiding the evidence and hiding the facts. So this is what we are trying to say. And more so, this operation theatre, ICU, closed spaces, where the patient is in closed spaces and the patient dies. Labor ward, closed ward, where the relatives are not there. It is not an open ward. These places, if there is a mishap and death, please hand over the body for the to the police. Animaka Sharma versus Chhattisgarh, wherein a patient was undergoing the physiotherapy, was taking the shortwave therapy for a physiotherapist every day. The physiotherapist that had put him on the machine and walked away for 10 minutes as usual. When she comes back, she finds him dead. Now, it is an elderly patient, but the hospital is very intelligent. Sends the body for post-mortem. They find atherosclerotic plaques. And later on, they definitely had a heart attack. So it was right that the hospital has handed over to the post-mortem because it was during a procedure. So therefore, please, if there is something during a procedure, don't try to issue a death certificate, but hand over to the police. In Vidya Devi versus Mahindra, here in this, the patient was admitted with high fever. After management of 1 week, the patient died. But the doctors, they had not come to a proper diagnosis, but they just said the patient has got a heart attack and tried to dispose of the dead body. Now, after the disposal of the body, the patient filed a negligence suit against the doctor saying it was admitted for fever. They have given a death certificate of cardiac problem, cardiac disease, and there is something mischievous. She had fever. What is this cardiac disease? From where it has come? And they issued a death certificate. Then ultimately, when the records were asked, it is seen that the patient had cerebral malaria. There were complications of cerebral malaria. Then that is what the doctor probably had not yet finalized or fully diagnosed, but treated for cerebral malaria. So the doctors could have issued something like that, or they were in doubt, should not have issued. And therefore, they were asked, where is the proof that the patient had heart attack? Show me the proof. In the death certificate, you have written coronary artery disease. Where is the proof? All your records show some malaria or cerebral malaria. Therefore, without evidence, do not issue a death certificate, and they were asked for compensation. And the last citation what I want to give is Ernakulam Medical Center versus Jayashree. Here there are two patients. One is the Purushottam and one is the Kanti. And one is suffering from chronic kidney disease. The other patient was suffering from heart ailment. Now these two people died. The bodies were in the mortuary. And the Kanti's relatives come. They were shown Purushottam's body by mistake, which they accepted, yes. I mean, long beard, long face. And it was a COVID time. From a distance, it appeared like Kanti. So they said, yes, it's my relative. Take and cremate. Ashes are there. Later on, the actual Kanti's relative come. And they show the Purushottam's body. They said, no, it is not our relative. Then the mortuary keeper said, somebody else has just now 3 hours back taken a body. They called maybe it is mistaken identity. They phone up the relative. They say it's already burnt. We can give you the ashes. So the hospital tells the patient, the relative, we can give the ashes. Accidentally, wrong body has been handed over. But they were very fussy, no. But ultimately they took it, they did the last rite, and Purushottam's relatives came and took the original body, again did the cremation. Ultimately, these people, Kanti's relative, went to the Supreme Court saying that this is a Supreme Court judgment. I mean, ultimately they went and they've said it has hurt our sentiments, right to religion, it's a right to constitution. It has hurt our this thing, emotions and sentiment about the burial, etc. And they got a compensation of 1.57 crores. So after issuing the death certificate, see that you hand over the right body to the right person. That's another thing. Now, next is now the second part of my talk. We'll go to documentation. These are the medical legal cases: assault, injury, burns, poisoning, drowning, etc., etc. I'm sure all of you all know what are the MLCs. Now, certain things about consent in Samira Kohli versus Prabha Manchanda Supreme Court judgment clearly states what are required in a consent form. Person has to be, the consent you have to take from the patient itself, not from anybody else. This has been passed on March 8, 2008. This particular judgment has been passed. If the person is an adult, if the person is mentally sound, the person is conscious, you have to take the consent from the patient and the patient alone and nobody else. Otherwise, the consent is invalid consent. The consent becomes null and void. Means in this case, Samira Kohli, where the patient was, so that is a basic thing. And also the judgment in this case, what happened, a young lady of 41 was taken for surgery. She was endometriosis for hysteroscopy for diagnostic purposes. And when it turned out to be endometriosis, her mother was told when the patient was under anesthesia that she has endometriosis and the ideal thing is hysterectomy. Since she's already under anesthesia, why not complete it? The mother gives a consent to the doctor and the doctor does a hysterectomy. And when the patient comes out of anesthesia, she conveniently tells the patient this is what has happened. The doctor shakes the head. Actually, she was engaged to somebody else and I was about to get married. After some time, the boyfriend and she file a complaint on the Supreme Court saying that without my permission, my uterus was removed. I was about to get married and I wanted the children and deprived me of the right to have the children. So then Supreme Court ruled that without the consent of the patient, you cannot do anything upon a patient. That is what the whole case is about. And in an you cannot, number two, what they said is that you cannot operate on something for which you have not taken consent. Please operate only for which you have taken consent. For example, if you have taken consent for scopy, in this case only diagnostic scopy, the consent was taken. One should have done the diagnostic scopy and come out of it. Even if you find something else, like in this case endometriosis, where a uterus had to be removed, the patient has to come out of anesthesia, counsel the patient, take the consent again from the patient for hysterectomy, and then only you can do the hysterectomy. So if you find some other condition when you open up the patient, you please have to let the patient come out of anesthesia and take the consent all over again. Doesn't matter if a couple of weeks or 3 weeks passes by, but that is the step. The only time that when you can do procedure surgery without the patient consent and you have already opened up is when the life of the patient will be shortened. For example, you have secondaries, metastasis, it will spread, and even a week or 2 weeks in delay will cause a worsening of the or shortening of the life of the patient. Then in good faith, you may proceed. And that section, even now in the Bharatiya Nyaya Sanchita, the new act, section 88, which was the old under IPC, now it is section 30 under Bharatiya Nyaya Sanchita, act in good faith will be accepted. So these are the things of Samira Kohli versus Prabha Manchanda and Ram Gopal Varshni versus Laser Side, wherein a cataract was performed in a 90-year-old gentleman where the consent has been taken from his 30-year-old grandson. The vision was 6/6 after surgery. However, post-surgery, the advocate who was aware of the Kohli versus Manchanda judgment, then the patient has to consent, filed a case against the ophthalmic surgeon saying that without the consent of my client, the doctor has performed the surgery, irrespective that he has got 6/6 vision. Now, the court ruled against the doctor saying, irrespective that he regained the vision, you have operated without a consent. Grandson consent is not a patient consent, and the patient was conscious and mentally sound. And the doctor who took only 50,000 for cataract had to pay 5 lakhs compensation. So please take consent from patient and patient alone. Kailash Moradia versus Punjabi Nursing Home. Again, the doctor had to pay compensation because the signatures were not clear. Relative signature was not clear. There were some scratches. The doctor himself had not signed. Incomplete gaps and spaces in the consent form. Please see that your consents are complete and your signatures are proper. T.T. Thomas versus Eliza shows the importance of informed refusal. Very often the doctors refuse, the patients refuse the treatment. They do not want admission when they require admission. They do not want surgery when they require surgery. When they do not want to do diagnosis when mandatory, they do not want to take chemotherapy when required to do so. In this particular case, a patient had a acute appendicitis and had to be operated immediately, but the doctor told the patient refused. Relatives said, we want conservative treatment, we do not want surgery, and the doctor obliged passing rice tube, antibiotics, etc. Within 12 hours there was a perforation, and the doctor then comes back to the relative and tells that if we do not operate now because of sepsis, the patient will die. He needs an emergency surgery, and later on they consent for surgery and the doctor operates. But you can imagine the sepsis in perforated appendicitis. The patient succumbs after 4 days, and after a month, the relatives go to the court of law where they tell the judge that the doctor delayed by 12 hours and therefore my relative died. And the doctor repeatedly hammers in the witness box saying, I repeatedly counsel them, they have to do emergency surgery, they who have refused it. And the judge then asks the doctor, please, if you say that you have advised them for surgery and you refuse, where is the evidence? There was no evidence. He said it was verbal. And the judge said you should have taken in writing, advised in writing that surgery is required and taken a refusal in writing, which was not done. Therefore, here comes the era where we have to have negative consent. You can have a standard consent form for refusal of procedures and print it out, write out whatever procedure you advise the patient has refused. You can write the repercussions of refusal of the procedure, including life-threatening, sepsis, hemorrhage, whatever it is. And then take the signature of the patient and of his relative and your signature as the doctor. Keep it with you. This is called informed refusal or negative consent. Keep it in your medical record file that you advised but the patient refused, and therefore the repercussions and complications including death. In Roger versus Whittaker, wherein he said that the material risk has to be mentioned. Very often when we operate, certain things, certain general side effects are the infection, hemorrhage, etc., etc. But certain specific things, surgery on a cervical spine has different side effects than surgery on a thoracic spine, then surgery on the right shoulder, then surgery on the left shoulder. In this particular case, it was a 35-year-old woman who had a squint. It was one eye was non-seeing, and she was about engaged to get married, and she wanted to correct this squint. She goes to an ophthalmic surgeon who says okay for the surgery, and he takes a consent, but he forgets to say this. One of the side effects of operating in a non-seeing eye is sympathetic ophthalmoplegia, which means that if complication is that even the seeing eye will lose the vision. That is 1% of the complication. That's all. But he did not mention, thinking it's only 1%, and therefore why to mention and why to scare the patient or drive the patient away, you see. But unfortunately, in this young woman, that is exactly what happened. She stopped seeing in the one eye that was seeing, and then therefore then the doctor later on had to compensate with a huge amount of money. You can imagine a person who could see with one eye now cannot see anything, and this is called material risk. Therefore, in your consent form, even if there is 1% chance of a rare complication for a surgery at a particular level, at different levels and different areas, the material risk is different. Different nerves are involved, different vessels are involved, etc. That 1% material risk, please write down. Very, very important. In Rohandeep versus Jaiswal, Rohandeep Jaiswal versus KDH, the consent was taken on the progress note, not on a standard consent form. Just some few lines, I agree to this, I agree to this. That was not held valid by National Commission. So prepare a proper consent form when you write your routine consents, rather than something out of the way you may take in progress note, but write it properly. Just a routine consent is taken in the progress note is not a valid, complete mentioning all the adverse effects, you see, and therefore was not considered proper. In Bihari Lal versus Jain, where the consent for gallbladder was taken, but also gallbladder and appendix was removed, it was deemed negligent because consent for appendix was not taken. in Gurudev versus Ramanna, where the consent, there no consent is required in an emergency. In this, there was an case of emergency where the patient had come with fracture femur, severe bleeding. They just took to theater, stopped the bleeding and operated. It was not without consent. It was an act in good faith. And this, the court excused the doctors because it was to save the life of the patient. So in life-saving circumstances, consent is not required, but you have to document it and also document that with the help of another specialist who specializes in the particular field, that in this case, it is a dire life-threatening emergency and there was no time to take consent. In Jaiswal versus M hospital, wherein the consent, the patient was operated 3 times. Patient came with aneurysm of aorta, so aneurysm of aorta was operated. Later on, a repair was done, exploration was done, and later on, after 5 weeks, the patient then had got sepsis. The amputation of the limb was done, and later on, the patient expired. And then the patient litigated in National Commission. Case papers was asked, but however they could not produce a consent for any of the surgeries. So let me this is to say that consent, if whatever you do, consents are mandatory documents. If surgery etc is done without consent, then in that case it is considered as if no consent is taken at all. So therefore, see that consents are produced when you produce your documents, and especially when demanded. Sterilization, blood transfusion, etc. The consents are taken. Blood transfusion and dialysis, every procedure needs a consent. Sterilization from both parties, you have to take the consent. Discharge card. Always see discharge card is prepared when the patient comes to hospital. That is mandatory. In Jaipur Janana, it was a surgical hospital. A prescription was given because it is a daycare surgery. There was no discharge card. And therefore, when they came back and went to another hospital, they had to spend a lot of time in knowing exactly what was done for the patient, etc. So when they went to court saying that, yes, the other hospital could not take care and there was a lot of issues, it was clearly mentioned that the previous hospital should have given a discharge card. Not giving a discharge card was deemed as negligence. In Lakshmi versus Gohel, it is clearly said that any instruction to the patient should be written down. Verbal instructions are not good. In this case, there was a fracture of the forearm bones and a plaster was put. And the doctor verbally said, come after 3 days for a check X-ray, and said after 1 month, come for a proper another checkup. But they had documented only that follow-up after 1 month. So the patient and the relative came only after 1 month, saying that the one for after 3 days was only verbally mentioned, not written, so it may not be important. At that time, when they come after 1 month, it was a malunion. So the doctor had to again set the union in alignment. So another surgery was required, for which the relative had to spend money. And therefore, they went to the court of law. And ultimately, the court of law said, you should have then told them, given in writing to them, that come after 3 days. So when the doctor said, I told them to come after 3 days, but they came after 1 month, the doctor said, it is not documented. Where is it written in the discharge card? Show it to me where it is written. The doctor said, I told them verbally 3 days, but documented after 1 month. So the judge said, it is not proper. Whatever, whether you say it or not, yes, it's nice if you explain, but what is more important is documentation. Please document in the discharge card what instructions you have to get. So therefore, it is the documented instructions in the discharge card which holds final. So that is it. Pre-op notes, pre-op evaluation has to be complete. In this case, where the patient was with a obese, a young person, the 35-year-old, without the pre-op investigations, pre-op anesthesia assessment, the patient goes for anesthesia, a young man of shoulder dislocation, and later on, the patient, the anesthesia is prolonged, and they had to intubate immediately. And they could not intubate because they had just given a sodium pentothal. They are not given a muscle relaxant. So the intubation was very difficult. It was prolonged, and ultimately, for whatever reasons, the patient then died, got a cardiac arrest and died. So later on, it was shown that the pre-anesthetic evaluation was not done, and the anesthetist mistook that it will be a very simple procedure, and maybe no issues because he's just 35. So in all cases of anesthesia, do the pre-anesthetic evaluation immediately and then only do your anesthesia. Very, very important, and document the notes. So these pre-operative notes are very, very important. Intraoperative notes in MC Katare versus M Hospital, where a patient was taken for a fibula implant removal. Now the patient goes there within 5 minutes, goes into arrest, and then the CPR is done. The patient is shifted to ICU. After 3 weeks, the patient dies. And here, what happens is the OT notes, the surgeon writes differently, the anesthetist writes differently. The time of coming in is the same. The anesthetist has shown that the patient is in OT for 15 minutes. The surgeon has shown that the patient is only for 5 minutes. Neither of them document that there was a cardiac arrest and CPR done in the OT notes. And the anesthetist writes implant removal from fibula. The surgeon writes arthrodesis, different diagnosis. Surgeon does not sign the OT notes, the anesthetist signs. And the reply to the litigation is totally different, saying that there was a cardiac arrest and CPR done. Lot of discrepancy between anesthetist and surgeon, lot of discrepancy between what is filed in the court and the written statement and the OT notes. Because of discrepancy notes, the hospital and the doctors lose the case. Post-op treatment, of course, post-op treatment is also very, very important. Your notes are important in this post-op case, Air Commodore versus LV Prasad, where the patient undergoes a cataract surgery, and post-operative, the patient loses the eye. Now, therefore, they file a case against the hospital and doctor, but the documentation of the hospital was perfect. They have documented the fumigation records. They have documented the strips of the CSSD, the biological strips, indicators that only sterile instruments were used, only sterile linen was used. The documentation was perfect. Also, the documentation of the medical records of the patient operated for cataract in the particular same theater before this patient was taken and after the patient was removed. None of them showed infection. And it was also shown this patient was elderly and diabetic, and therefore it was mentioned. Maybe he did not take proper care after he was discharged, but while he was in the operation in the hospital, the care was taken, the documentation is perfect. In Mohammad Aslam versus Ideal Nursing Home, where post-operative, the patient was advised NBM, but the patient took meat, puree, egg, etc., lot of dehiscence, and then there was a rupture. Secondary suturing was patient was wheeled in, and then the patient was comorbid, obese, and the patient expired. And they filed a case of negligence. It was shown by the doctor and hospital that they were advised nil by mouth, but the patient, in contradiction to the advice given by the doctor, has had solid meals. And that is why the patient, it was contributory negligence on part of the patient. Anything that the patient does not adhere to the doctor's instruction is contributory negligence, and therefore the patient expired and the case was dismissed. Constant monitoring in ICU, constant monitoring by anesthetist is very, very important. And that is important. Assessment in emergency room is important. In Amir Ali Shakir versus St. John, where the patient was came with multiple injuries, and in ER, lot of treatment was given, seen by the neurosurgeon, seen by orthopedic surgeon, IV given, IV blood given, the diagnostic CT/MR, biomedical done, biochemistry, etc. And patient taken to the OT for 40 minutes. After 40 minutes, after all this was done, the extensive surgery done, but the patient succumbed. Later on, they file a case saying there was a delay in transfer to surgery by 40 minutes. But that is why the patient died. But the hospital proved every minute in the ER, something or the other has been done. The documentation was so perfect, so that the judge passed the order that the standard of care was given, even though the patient was waiting in ER for 40 minutes. Everything that needed to be done was done, and therefore there is no negligence. Hence, documentation is very, very important. So prescriptions, we have to write very clearly. I think the time is running out, and transfer summary, even if the patient is discharged against medical advice, has to be given, because only then the next hospital will come to know everything was done in the previous hospital. And now in this case, Apollo Hospital versus Satyanarayana, the patient had come with a paddy field instrument injury for the shoulder, and damaged his shoulder dislocation, and then all treatment was given, etc., and transferred to a new hospital, another hospital. The summary showed everything. So the next hospital did not waste the time in finding out the diagnosis, what happened to the patient. They could continue the treatment, and therefore there was no negligence. So therefore, in another hospital where the complete notes were not given, they wasted a lot of time to find out what was the initial ailment, what treatment was given, diagnosis ke liye what time they wasted, and the patient lost his life. So when you give a transfer summary, even if the patient has left against medical advice, continuity of treatment is very important. Therefore, we have to give the progress notes, etc. Retention, a patient has to keep the record for 3 years. Hospital has to keep the patient for 3 years. In this case of Sham Kumar versus Ramesh Bhai, where the cataract and detachment was done, all the consents taken, all the documents carefully preserved. But then in the court of law, though asked within stipulated period of 3 years, they could not produce the records. They had misplaced the records. The hospital lost the case because of non-production of documents. Therefore, non-production of documents in a court of law would have adverse inference, and the doctors and hospital lose the case. Please keep your records carefully and produce it in the court of law when demanded. So this is about documentation, initial assessment, transfer, referral notes, procedures, anesthesia notes, surgery notes, diet orders, medication, consent. Let it be legible. Put your date, time, brief history of allergy. Second opinion can be taken if required, diagnosis under review, informed consent, discharge card, etc. So e-records are passed in by the IT Act as well as Indian Evidence Act, and therefore it is valid in a court of law. The last part of my talk is about Mishap Management. A good deal has been already been given by Bela doctor in the initial talk about the how to communicate, and also the first two talks by both Dr. Zubin as well as Dr. Bela would really help in all the doctor-patient communication. Very, very important. I'll just pass a few case laws, and these are case laws at National Commission, and how the Mishap has made judgments against the hospital. In the first case, Mission Hospital versus C, wherein LSCS was done, mop was left accidentally behind. The doctor on the routine rounds, patient says, doctor, there is pain in abdomen. The doctor says it is acidity, discharges the patient. Patient goes to another hospital, they do the ultrasound, etc., MRI, etc. They find a mop. Again, operation, money is spent, and then the mop is removed. So therefore, what the doctor should have done the investigation, seen, yes, okay, an accident has occurred, a mop has accidentally been left behind, and therefore said, see, I'm sorry, these things have happened, but now before you got discharged, you have diagnosed, removed the mop, may have even waived the fees. Hospital could have waived the fees. And if the patient got discharged with some proper transparent talk, maybe the patient may not have been litigated, because where complication was created was taken care by the initial hospital. In the second case, where the patient has an IV and there's an extravasation of fluid, but the doctor says, no, there's a small swelling, give some thrombophobe or give some gel and say it will get okay, you just go home. They go to another hospital, there is a gangrene, and the right lower limb had to be upper limb, lower half had to be amputated. How painful. What the doctor should have done is spoken, investigated, seen, admitted, yes, there's a counterpuncture. It does happen in such things. Taken care and, done the needful. Immediately, things would have been under control. In the third case, a tight plaster, lower limb, and they say, no, it's all will be okay, you go home. After a few days, gangrene sets in. They go to another hospital, leg is amputated. Naturally, they're going to go for litigation. What the initial hospital should have done, observe the patient, little bit loosen the plaster, cut the plaster, things should have been okay. That should have been done. Face problems. And the last case, mismatched blood transfusion. So instead of just trying to get over things, what the people should have done. Now, commonly it does happen. Anesthesia, you do have anesthesia-related event. You do have patient death in a OT immediately post-procedure. Instruments are retained, mops are retained. Breakdown of instruments happen. Then a slip, a trip, a fall, electric shock. Bed rails are removed and the patient rolls down. and falls. You see, like in that Santosh Hospital versus Parikshit Dalal, wherein a case, a 32-year-old pregnant, 36-year-old pregnant female was whirled into the OT, and instead of getting the good news, they get the bad news, she has died. And then they refused to accept death, the order of post-mortem, and then you have the hemoperitoneum, the pelvic bones ruptured, etc., fractured. And then they find that the patient has fallen from the OT table onto the ground because the side rail has missed out, and anesthetist has given anesthesia and not noticed it. So these are the simple things. Mishap happens. You see, medication error, etc. So therefore, mishap does happen. Kiska haath mein sab kuch theek hota hai? No doctor can say 100% success. Even if you have 999 or 9,099 surgeries perfect, the 1,000 case or 1 in 1 lakh, some mishap can happen. Even the best of hands, things do happen. But what one needs is a humility. One needs to accept, yes, things can happen. I'm not God. I'm a human being. Therefore, instead of trying to just come out of the situation, accept it, talk it over the patient, whatever damage has been done has damaged, try to save the rest. Half of the glass of the water is spilled, save the rest half. So some damage has been done, okay, salvage the rest. And be transparent, tell the patient, be honest, be documented, and try to get legal help, try to get the police, because if it's a death and it has to be handed over to the police, hand over. If in case there's a mob violence, the police are always there. But, and again, do not say sorry, because if you say sorry, they will say it is a mistake. Say it, be polite, be firm. Say it could have happened. You may waiver your fees after that. That is okay. That is okay. So this is the way it is done. So, and don't show your attendance. This is done, that is done. Don't call them to ICU and operation theater. This is, etc. But be honest. Try to control, try to salvage. So as in the cases which I show, things could have been handled better. Mishap, and as has been told earlier in this talk about the good, be very polite, be very courteous. This is how you, this thing. And today, things are in crores, not in lakhs. Earlier, they used to win 5 to 10 lakhs. It was a thumbs up. But today, things are gone into crores. And all the litigations you have now in 20 crores and 10 crores, your indemnity has to be higher. And today, earlier, people used to indemnify for 2 lakhs and 5 lakhs and 10 lakhs. Today, physician, junior physician also should be minimum 50 lakhs or even 1 crore, according to me. And surgeons and senior physicians about 2 crores. Very, very important, because the litigations are all in crores today. And even the compensation are going into crores. So therefore, this is the way things are. So thank you so much for a patient hearing. And let's hope I made some effort to make you little, give you say some knowledge, and I hope it has been an advantage to you. And I thank the SRCC for giving me this platform. Thank you so much. And if there's any question answer, I invite you. Thank you.
Thank you, ma'am. Thank you for this wonderful talk. I think we've all learned a lot with respect to medical legal aspects, especially documentation and certificates. Ma'am, thank you so much. I would like to introduce the next speaker, Mr. Gautam Tiwari. Sir is a lawyer by profession. He's a managing partner of Probus Legal and specializes in criminal law. He's also an alumnus of the London School of Economics and one of the top managing partners by Forbes this year. I welcome you, sir.
Thank you so much for your kind introduction. Hello, everybody. Good evening.
Good evening, sir.
Ladies and gentlemen, it is indeed a pleasure for me to partake in this discussion and to give my 2 cents on the aspect of POSCO and adolescent consent. These are the topics that I shall be briefly touching upon. Going through what is POSCO, what is essentially consent therein, how it has been interpreted by the courts, and the age where one can be considered old enough to give consent in relation to POSCO. So we are talking about sexual consent. Now, age of consent has been quite a topic of discussion of late. The age of consent in law is considered as an age where a person is assumed to have enough experience in life, possesses the mental acumen to take informed decisions for himself or herself, and more importantly, understands the consequences of their decisions. Under penal provisions, the age of consent since 1940s was 16 years, which in the year 2012 increased to 18 with the enactment of Protection of Children from Sexual Offences Act, as we call POSCO. What is POSCO? Enacted in 2012, POSCO is a comprehensive legal framework which is designed to safeguard children from sexual abuse and exploitation. It essentially protects anyone who is under the age of 18 from various forms of sexual offenses, including sexual assault, harassment, and pornography. Essentially, the Act criminalizes sexual acts with minors, irrespective of the relationship they may be in, and makes no exception for the consensual sexual relationship between two minors. Moreover, it also mandates that any individual who comes to know that sexual act has taken place in relation to a minor is obligated to report it to the authorities. POSCO, in that sense, is a very special legislation. It was enacted to plug various loopholes that existed prior to its enactment. Now, as things stand today, I came across a report of the 2011 census, which says that India has about 472 million children under the age of 18 years of age. Now, protection of such children is enshrined under Article 21 of our Constitution. And also because India is a signatory to the UN Convention on Rights of Child. So it is obligatory on part of the state to come out with comprehensive measures to prevent child abuse of any form whatsoever. Before implementation of POSCO, there used to be a legislation by the name of Goa Children's Act of 2003, which was possibly the only legislation in the country, one of its kind, to protect child abuse in any manner. What would happen before the enactment of POSCO is that any child sexual abuse would be tried under the provisions of the Indian Penal Code. If there was some penetration, it would be rape under 375. Outraging modesty of women was made an offense under Section 354. And Section 377 was for unnatural offenses, and so on and so forth. Wherever what offense came about, it was tried and tested under the Indian Penal Code. But such measures did fall short of what was required, what was the need of the hour. For example, Section 375 for rape was only in terms of the traditional vaginal intercourse. It did not protect male victims. 354, though was for outraging modesty of the women, did not cater for modesty of a male child. 377 was for unnatural sex, but unnatural sexual offenses was also not defined. So it was getting very difficult for the prosecution to put its case forward under these parameters. In that sense, POSCO seems to be a step forward. Child or children as defined under the Act are individuals aged 18 or below, irrespective of their gender. So in that sense, it becomes gender neutral. Now, different forms of sexual abuse, which were not catered for under the Indian Penal Code, have been added and have been brought about, such as sexual harassment, pornography, and sexual assault itself has been divided into penetrative and non-penetrative. One sees Section 3 of the Act. It deals with what we may refer to as the traditional form of sexual assault, a penetrative traditional attack. Section 4 gives its imprisonment of 4 years for it. Similarly, such a penetrative attack for the first time can be deemed to be aggravated if the abuse is committed by somebody who the law refers to as somebody that the child may have trusted. Such an individual could be a family member, could be a teacher, could be a policeman, and also can be a doctor. Similarly, Section 7 expands the ambit of sexual assault to be non-penetrative. It states that anybody who touches any reproductive organ or any kind of unwanted touch itself will be an offense under the Act. Provisions are there for imprisonment up to 3 to 5 years for somebody who's been found guilty. Again, this kind of sexual assault of non-penetrative nature becomes an aggravated assault if it is committed by an individual who the child has a trust in, which I explained earlier, could be a doctor, teacher, policeman, or a family member. In fact, an attempt to commit any kind of sexual assault on a child itself has become an offense under the Act. For the first time, notably, the Act also provides and recognizes sexual harassment of a child, which involves the act of stalking or making the child expose themselves or exposing of an individual before a child. So that also should be one thing. If the audience primarily are of doctors, they need to be absolutely sure of the fact that anything that requires a medical treatment where it is an invasive procedure, they have to be very sure that proper consent and proper information has been provided, because then the section 11 may come can become a bane for them. Moreover, under section 19 of the Act, it is now become obligatory on part of anybody who has knowledge that a sexual assault has been committed with vis-a-vis a child has to report it. Section 20 of the Act actually makes this very obligatory, especially upon the personnel of media or hotel, lodges, and also hospitals, that if they come to know about any sexual act or they come across any material or object which they think is exploitative for the child, they have to report it either to a special juvenile unit or the local police. The issue is, if any failure happens on part of an individual or the hospital or the institution, that failure to report is punishable for the first time under the Act. The person who fails to report may be imprisonment with 6 months. And if an establishment or a hospital fails to report it, then the people who are in charge of such establishment or the hospital can be imprisonment by a year, 1 year, with or without fine. Now, it's very good, yes, that somebody came across an offense that may have involved a child and did the best and reported it. But there is a word of caution. Because sometimes what happens is there is always a tendency to misuse the Act. So POSCO in itself provides that if a report that has been made and could be with the best of intentions is deemed to be a false report, deemed to be to humiliate an individual or to victimize the child itself, then such a false reporting itself is punishable. So one has to be very, very careful that when they report, that proper facts and circumstances are in their knowledge, and that when they report substance, and it cannot be a hearsay. So that's a word of caution. Especially for medical practitioners under the Act and under section 27, it mandates that any child who's a victim of any sexual assault, be it penetrative or non-penetrative, the medical examination needs to be done in terms of section 164A of the Code of Criminal Procedure. In short, this section 164A deals with how medical examination in case of a rape or an attempted rape needs to be done. So all those safeguards need to be taken. If a girl is a victim, the medical practitioner examining her has to be a woman. Such medical examination needs to be conducted in presence of the child's parents or somebody that the child reposes faith in and has trust upon. If there be a situation where parents are not available and there is no individual who the child really trusts, then it is obligatory on part of the medical institution, the head of the medical institution, to nominate a lady doctor to do that. But apart from such welfare or forward provisions, there is also a drawback, an inherent drawback in POSCO. It is an act which is a little deviated from the normal criminal jurisprudence. What happens in normal criminal cases, and an accused is presumed to be innocent until proven guilty beyond any reasonable doubt. So essentially, it is for the prosecution to prove its case and not for the defense to defend. But under Section 29 of POSCO, what has happened is the onus to prove himself innocent is casted upon the individual who's been accused. So the prosecution need not prove its case beyond reasonable doubt. It is the onus is upon the individual to prove his innocence beyond reasonable doubt. So that becomes all the more difficult given the stringent nature of the legislation itself. Not only that, once we are talking about the age of consent, the age of consent itself is not defined properly in the Act. So anybody who's perceived to be 18 and below, and anybody who indulges even in consensual sexual relationship with either another minor or a major, then that individual itself or herself himself is going to be prosecuted under this act without any criteria, any discretion being given on the circumstances and the nature of crime. So now when you're talking about age of consent, which was earlier 16, so there exists a gray area of what happens in case of any sexual activity undertaken by an adolescent, and that adolescent is an individual who possesses the mental acumen and the understanding capabilities of his or her action. There is a gray area of who the law actually recognizes as adolescent. There are various legislatures which have different criteria. To give you an example, there is a Child and Adolescent Labor Prohibition and Regulation Act of 1986, which defines an individual as an adolescent if he or she has completed 14 years of age. There's a Factory Act of 1948 that defines adolescent as somebody who's completed 15 years of age. There are legal dictionaries like the Black's Law Dictionary, which defines the age which defines adolescence as an age which follows puberty but precedes the age of majority. But what can safely be said that under POSCO, the adolescents or the age between 16 to 18 is something that we are going to concentrate on, because that is the age where an individual does have the mental acumen to take care of himself or herself, but has not reached the age of majority. Because of the stringent provisions of POSCO, which has also become a bane for the criminal jurisprudence, a lot of cases are coming forth where we see the victim is between 16 to 18 years of age, was a consenting minor, may or may not be in a romantic relationship. And if she was in a romantic relationship, she may be pregnant or may not be pregnant, is willing to get married to an individual, is willing to have the child and live like a family. But any such relationship is looked upon at par with rape under the POSCO Act. There is no laxity given whatsoever for any excruciating circumstances. It also creates a lot of fear in an individual, because for the basic medical healthcare checkups also, the individual may be very wary, because as a doctor, one is obligated, if he or she comes to know that yes, there is an apprehension of sexual act being committed by a minor, uh, with a minor, by a minor, or by a major, irrespective of that, the doctor is obligated to inform the authorities. And once the authorities get involved, it's a straight registration of a criminal complaint or an FIR followed by a charge sheet. So, irrespective of the excruciating circumstances or a romantic relationship being there, what we see in majority of the cases is that the boy is sent to jail or juvenile justice home, with whatever the case may be, spends there until he comes out on bail, and then individuals have to go before the high courts for quashing under Section 482 of the or in writ. But it's a long and tedious process. Nobody can deny that it causes extreme mental agony to both the perceived victim as well as the perceived accused. It causes immense social boycott. People have had instances where what I can say, their value in society has decreased for their relationship, which everybody knew about. There's a lot of stigma attached to it. There are cases where women have been pregnant with or without knowledge of their parents. The parents have refused to take such individuals back home, so they feel they are orchestrated in society, and possibly the only pillar of support that boy with whom the girl may have had relationship with, he is languishing in jail, is not being able to come out. So a lot of dismay is there, a lot of issues that come across. And also what is very pertinent to note in that in all these cases under POSCO, where the angle of romantic relationship is there, there are not many convictions for obvious reasons. There was a 2023 report and perusals of the judgment disposed by the Mumbai Sessions Court. There are two Mumbai Sessions Court, one is in Dindoshi and one is in Bombay City. So it seems there were 59 cases of POSCO under various sections that were disposed of by these session courts. And out of these 59 cases, 33 cases related to romantic relationships. That's about 56%. And in all these 33 cases, which involved romantic relationships, the accused was acquitted. It essentially points out to two things. It denotes that the victims who are perceived victims under the Act are not victims, as they may not have any grievance against the accused. Such complaints, more time than less, are initiated by their family members or suo motu by the cops themselves. There have been instances during the acquittal process that the girls turned hostile during cross-examination because as they were in romantic relationship with the individuals. So the effect of the act, which is a welfare act, a welfare legislation, is very detrimental to the interest of individuals who may not have achieved the age of majority, but mentally possess everything that a major person does. Moreover, the ambit of POSCO, instead of there being a thought over about the age of consent and all, the ambit is being expanded, and in certain cases, rightly so as well. If you take the instance on Monday itself, the Supreme Court, in a very landmark judgment, the bench of Justice Chandrachud and Justice Padriwala, have ruled that even downloading of child pornography and viewing child pornography would itself come under the act of POSCO and will be an offense therein. The decision overturns a Madras High Court judgment which says that just downloading for private viewing, etc., may not constitute an offense, but the Supreme Court held otherwise. And in fact, it went a step further to recommend to the government that an ordinance may be passed where child pornography may be defined as child sexually abusive and exploitative material. So at one instance, the widening of the ambit of the act is welcome, but at the other end of it, we need to really take an introspect of how this particular strata of society of the adolescent and how their consent and how their rights over their own body and their own expectations of themselves need to be addressed. Things, as bleak as they may think, are not that bad when it comes to the judicial outreach that happens. Because at times legislations are passed keeping a certain criteria in mind, but it is the judiciary that comes forth and in its interpretation comes out with various judgments that genuinely do offer a ray of hope for individuals who are stuck in this catch-22 situation. Now, judicial activism in such sense goes back to 1965 in a case of S. Vardarajan. The citation is for anybody to know. AIR 1965, Supreme Court 942. Now, dealing with the concept and dealing with inducement in context of kidnapping and in context of punishment for kidnapping, the Supreme Court observed in relation to a 17-year-old girl that she was not, and I quote, she was not a child of tender age who was unable to think for herself, but had already stated was on verge of attaining majority and was capable of knowing what was good and what was bad for her. She was not an uneducated or unsophisticated village girl, but a senior college going student who had probably all her life lived in a modern city and was thus more capable of thinking for herself and acting on her own than perhaps an unlettered girl hailing from a village. And rightly so. The Supreme Court was able to appreciate her surroundings, her acumen, her exposure of life, and come to the conclusion that she, being an adolescent, possesses enough capability to take independent decisions for herself. Now, coming from such line of thought, what has happened today is in a case of an adolescent's consent to sexual activities, and in cases which have been registered under POSCO, which come under the ambit of romantic relationship, it is left for the courts to go without there being a specific criteria for various courts to go and exercise their own discretion when coming up with on a case to case basis, let me add, on a case to case basis to see what the circumstances are without there being any legislative guidance towards that. Bombay High Court, in the case of Ashik Ramjan Ansari, criminal appeal number 1184 of 2019, and the judgment was delivered in 2023, overturned a conviction on ground that there was a romantic relationship between the perceived victim and the accused. Justice Bharati Dangre had penned that judgment, and it is a landmark judgment in that sense. Similar views have also been taken by various other high courts and also the Supreme Court. In fact, in the case of Bande Rama versus State of Karnataka, Criminal Writ Petition 6214 of 2022, the High Court quashed criminal proceedings under IPC and POSCO, again holding that there was a consensual sexual relationship between the minor girl and the major boy. In fact, Madras High Court also observed that punishing an adolescent boy who enters into a consensual relationship with a minor girl was never the objective of POSCO Act to go about. This was held in the case of Vijay Lakshmi was a state representative. Criminal Writ Petition 232 of 2021. Similarly, the Honorable Calcutta High Court has also been very pragmatic. In Criminal Appeal number 458 of 2018, Justice Bhattacharya noted that the physical intimacy between the accused and the victim and the recorded age of victim at that instance was 16 years, but below 18 years, was inconsequential because there was a romantic relationship between them. He also posed a very moot question. Under POSCO, how come a consent will be disregarded when a girl reaches the age of 17 years, say 364 days, but the very next day, that is on 17 years and 365 day, when she turns 18, she's capable of recording a consent, and that will not come under the Act. So such questions have been time and again brought forth, and attention has been drawn to them, and the legislature in a certain sense has been nudged to actually give it a rethink. The Karnataka High Court, in the case of State of Karnataka versus Basavaraj, in Criminal Writ Petition 104281 of 2021, has in fact posed a question and asked the Law Commission to rethink the age of criteria for consent under POSCO Act. Similarly, Justice Deepak Kumar Agarwal of the Gwalior High Court also, while deciding a case under POSCO, which essentially dealt with romantic relationship, also drew the Commission's attention on how enforcement of POSCO legislation in the most stringent manner, in the manner that the legislator intended that it be applied, causes grave injustice in cases where de facto consent is present, and it requested to Law Commission to look into the aspect whether the age of consent under POSCO can be uh, can be made discretionary or can be amended. Our Chief Justice, Justice Chandrachud, has also been a very vocal propaganda surrounding the age of consent under POSCO on multiple occasions. And also, I remember on the inaugural sessions at the National Stakeholders Consultation on Child Protection, he had raised and he had called upon the government and the legislature to have a rethink on the age of consent, because ultimately from 1940s until 2012, it worked well. It absolutely begs no question of any sort that anybody who's 15 or below should actually be protected irrespective of what their mental acumen is. But this strata of society between 16 and 18 deserves to be reconsidered. Now, given such judgments were coming from the high courts, and given that two of the high courts in India, that being the Madhya Pradesh High Court and the Karnataka High Court, specifically called upon the Law Commission to rethink the age of consent criteria under POSCO, the 22nd Law Commission was established and was tasked to look into this very question of age of consent to sexual activity in relation to POSCO. There were substantive issues that was given to the Law Commission to decide upon. They revolved primarily upon lowering of age of consent to prevent unnecessary prosecutions of individuals who may be in romantic relationship, and also to resolve the contradiction in sexual violence law vis-a-vis the welfare regulations that exist in the country. Now, the commission, in all its wisdom, it consulted and came about with a report in September 2023, being the 283rd report. Like with many things in life, there were a lot of suggestions made, there were a lot of hopes, but little came about it, and much is left to be desired post. The Law Commission did not suggest lowering of age of consent. So as of date, the age of consent remains 18. The legislature also does not seem to be in any hurry to give it a think. What Law Commission did, rather than coming to the question and nailing it right on the head, it rather suggested a few things that could be considered by the legislature. It said that the courts, the special courts that have been enacted under POSCO, if the offense has been committed on a child who was 18 or who was 16 or above, and if the courts are satisfied that yes, there was an element of romantic relationship between the victim and the accused, then the court at its own discretion may give a lesser sentence than 10 years. I mean, it hardly takes what is required in the given scenario, and it falls miserably short of the need of the hour. What the Law Commission also did, the special court could not just use its discretion. While using its discretion, there were certain parameters for the special court to consider. It had to consider the fact that the child, the victim, has to give his or her approval. The age cap of the accused and the victim could not be 3 years. I mean, that is a criteria that has been that makes little sense to me, to tell you the truth, but that is what is being proposed. The accused should not have any criminal antecedents and should be a man or a woman of good conduct. And the accused marries the child or the victim upon the victim attaining the age of majority. So these were the criteria set forth the special courts to consider if they, in their wisdom, wanted to give a lesser degree of punishment to the accused. But what essentially the Law Commission did was to step aside from the main issue. And now what happens is the matter rests on a case-to-case basis at the discretion of the court, whether the court would actually consider it as an excruciating circumstances and would use its discretion to quash the proceedings, or the court may, in its wisdom, decide not to do that. So there is no fixed yes or no as it exists right now. What the Law Commission, the 22nd Law Commission, also did not pay heed to an earlier report by the Justice Verma Commission in the year 2023, which specifically in relation to POSCO had made a recommendation that the age of consent should be reduced from 18 to 16. And in fact, that report was only published after a lot of deliberations between the stakeholders. And apart from Justice Varma himself, eminent Justice Leela Seth was also a part of it, and eminent lawyer Gopal Subramaniam was. They were the panel, and I believe that recommendation should have been transformed into law right now, but we still don't think anything is going to happen. Like I said, the legislature does not feel inclined to touch upon this object anytime soon. And the Law Commission also did not give any specific recommendations wherein the stringent provisions, any discretion should be given to any other excruciating circumstances apart from a romantic relationship, which can possibly influence the decision of the special courts, or which may also not have that much of stigma attached to it when it comes to an individual getting prosecuted. What I feel is that there has been a slight overreach by legislation in its enthusiasm of coming about of a legislation in the year 2012, possibly because of the circumstances that prevailed in the country, and possibly because of the crime graph going high in terms of sexual acts on children. But if 16 years was a consent and was absolutely fine for more than 80 years, there was no reason for it to be increased to 18 years under POSCO. And in fact, if one was to also read the statements of objective and reasons why POSCO came about, it also does not throw any light on such a decision being taken. There is also a fact that there was a report by National Family and Health Survey, which reflects that about 11% of girls have had their first sexual intercourse before the age of 15 and 39 before the age of 18. So if the fact is hitting, if the numbers are hitting us, and this is what the ground reality is, I think it is high time for the legislature to wake up and, at least for that age bracket between 16 and 18, decriminalize sexual activity when there is a consensual relationship or when there is a romantic relationship between the victim and the accused. As of date, one has to bear in mind that sexual autonomy in today's day and age, it encompasses both the right to engage in wanted sexual activity and the right to protection from unwanted sexual assault. And it is very, very obligatory on part of the legislation to draw a fine line between the two. And it's high time for the legislature to increase, to reconsider the age of consent. And until that does not happen, like I said, my only 2 cents to all of you guys would be that please stick to the stringent provisions of the Act. Non-disclosure itself is an offense. Please disclose any circumstances that you may come across to the relevant authorities that point out to sexual activity being undertaken by a child or undertaken upon a child. Be very thorough with your consents. Be very thorough with your reporting, and be very thorough of the facts and circumstances of cases that come to you. With that, I think I've said everything that I wanted to. If there be any questions, I'd be more than happy to take it. And I again thank everybody involved with this, including SRCC Hospital, to give me an opportunity to present myself. Thank you.
Thank you so much, sir, for this wonderful talk. You've really helped us clear one thing. As long as POXO is there, we have to take 18 as the cutoff.
Absolutely.
Irrespective of the adolescent consent, there's still gray areas. And of course, as you said, it would remain in the individual courts to decide for less than 18. So this is a very important take-home point for us as doctors, gynecologists, pediatricians, all of us. Thank you so much, sir.
Thank you,
I'd
Zubin.
like to take this opportunity to also thank all our speakers, Dr. Bela, Dr. Zubin Pereira, Dr. Suganti and Mr. Gautam, thank you very much. I'd like to thank NHSRCC as well, and of course, all our audience. If there are any questions, we just wait for another 5 minutes. Please, you may ask questions or you may even post them in the chat box for all of our speakers. And thank you everyone for your patient hearing. Thank you very much.